There's the tolling bell. And Thank you so much for being here. So, good morning, everyone. It's my distinct privilege to introduce Dr. Nicole Schmitt as our grand round speaker this morning. Dr. Schmitt is associate professor in the Department of Otolaryngology at Emory University School of Medicine and is co-director for translational research for the head and neck program at Emory's Winship Cancer Institute. She received her MD at WashU, completed a research fellowship and a residency at University of Washington, and carried out her fellowship in head and neck surgery and tumor biology at University of Pittsburgh. She has made significant contributions to the field of head and neck surgical oncology with almost 65 publications. Her research focuses on characterizing the immune effects of cytotoxic chemotherapy and designing optimal combinations of chemotherapy and immunotherapy for head and neck cancer, including a recent multi-institutional phase 2 trial of pembrolizumab and cabozantinib for current metastatic head and neck cancer. I think what makes her work particularly compelling is her exploration of novel therapies for head and neck cancer, such as inhibitors of apoptosis, protein antagonistic drugs, statin drugs, and other immunotherapies. And we're so lucky and privileged that she's here to share her expertise with us. So today she's going to be talking about the utility of statin drugs in head and neck cancer. Please welcome me in joining Dr. Nicole Schmitt. Thank you so much for being here.
Thanks so much, Michael. And thanks to you and Dr. Hoff for inviting me. I'm delighted to be here to talk to such a wonderful department about some of the work we're doing on drug repurposing. So these are my disclosures, none of which are related to this talk because there's really no industry incentive to invest in research on a drug that costs $4 at Walmart. So let's revisit statin drugs that we all learned about in medical school, and a lot of our patients are on them. So just to remind you, these are HMG-CoA reductase inhibitors. So if we look at how cholesterol is made within every cell in your body, this is what we call the mevalonate pathway, and statin drugs specifically block this change from HMG-CoA to mevalonate, which then turns into cholesterol. So the way statins work is that if cholesterol can't be made in the cell needs some cholesterol, so it actually will increase the LDL receptor expression on the cell surface. That brings more LDL cholesterol in from the serum, and that's how it lowers the serum cholesterol and reduces risk of heart disease and so forth. But as many of you have already heard, these drugs have a lot of other off-target effects that can be beneficial, such as anti-inflammatory, neuroprotective, and more recently, immune-enhancing effects that I'll tell you about. So it turns out about half of our patients with head and neck cancer should be taking these drugs for cardiac or other indications, but often 40% or less of them are on it. When I was practicing in Bethesda, Maryland, it was a relatively affluent population. About 40% of our patients were taking those drugs. Here in the South, somewhere between 25 to 40%, depending on which of our databases that you look at. So I'm going to talk about these drugs in the context of head and neck cancer in two ways. First is the reason I got into it, which was related to survivorship. So specifically prevention of cisplatin ototoxicity, prevention of radiation fibrosis, and prevention of radiation-induced stroke. And while I was learning about those things, I came across data to suggest that it actually increases survival. So there's known to be superior survival in patients who are taking statins at diagnosis of head and neck cancer. And there are emerging studies suggesting that there may be enhanced responses to immunotherapy. So I'll show you some of that work, as well as some work done by others in the field, not by us. And I want to point out that this is team science. These are several of the people that have been helping with these studies over the last several years, and none of this is work that I've done by myself. So I'll be reintroducing these folks along the way and how they've got involved in this. So first, really, all of this started back when I was at my first faculty job. I was at NIH, where I had a lab, and I also had my clinical practice at Hopkins with a satellite location across the street from NIH. And I was working with Lisa Cunningham, who's clinically trained audiologist, but now scientific director at NIDCD, and Kate Fernandez, who's also an audiologist/scientist. And so they have been studying mechanisms of cisplatin ototoxicity, which is what I did during my T32 years in residency. And we know that cisplatin causes a permanent high-frequency sensory neural hearing loss. And Lisa's lab had shown that heat shock proteins reduce the toxicity in animal models. And since statins are known inducers of HSP32, one of her graduate students thought that maybe statins could be helpful in this context. And interestingly, there are papers out there suggesting that statins can actually reduce hearing loss caused by noise aminoglycosides and aging in animal models, but it had not been done yet with a model of cisplatin toxicity. So they did this in an animal model, and they showed that it appears to work. So that's great and wonderful. But the next step was, let's look back at audiograms on patients who are getting cisplatin chemotherapy, and a lot of them should be on statins, right? I told you that about half of our patients have indications to be on these things, but it turns out to be harder than you think, because a lot of centers are not ordering audiograms and doing routine ototoxicity monitoring. So it turned out to take us several years to actually get reasonable data to draw any conclusions. So we first started by making a prospective clinical trial at NIH and Hopkins. So we would show up to patients' simulation visits for their radiation at our satellite Hopkins clinic with a portable audiogram on an iPad and calibrated headphones, and we would enroll them and get their audiogram. And then we record whether they're on statins or not, and we do another audiogram after they finish their treatment. But this was slow going, and we only got about 28 prospective patients over, course of a year. Wasn't a very busy center, and but luckily I knew that Sean Newlands, the chairman at Rochester, is one of the few people who is a head and neck cancer surgeon that cares about the ear. And Sean has actually been collecting data like this for years, and he had actually data sitting there on a couple hundred patients. So we were able to get those retrospective data from Rochester, as well as some retrospective data from Walter Reed, which is in our backyard in Bethesda. And altogether, we had data set from almost 300 patients with pre and post audiograms and data on whether they were taking a statin drug. And what we found was, if we look here, this is, as you know, a threshold shift, which is the difference between the post-treatment threshold for that frequency and the pre-treatment threshold. And as you know, you're going to see more threshold shifts in the higher frequencies, is what cisplatin does. So when we looked at patients taking no statins, not surprisingly, we see high frequency threshold shifts. But then when they were taking any statin, there was significant protection at the higher frequencies. So we looked into individual statins, and the most common one that we use, not only in the United States, but worldwide, is atorvastatin. And what we found is that atorvastatin is significantly protective, but simvastatin, which is the second most common one in our database, was not protective at all. What is the mechanism for this? We haven't a clue. But what we learned here is that statins are not created equal. And that sort of concept stuck with me as I moved into other arenas with statin drugs. So we looked at it too in a little bit different way by CTCAE criteria for hearing loss. These are the guidelines by which the National Cancer Institute recommends we grade our toxicities on clinical trials for cancer. And more than grade 1 is something usually the patient would notice. And so when we look at patients who were on no statins, about half of them had hearing loss. And this is a mix of patients that were treated with weekly low-dose cisplatin or higher dose every 3 weeks. It's about an even split. And then if they were on statins, it dropped to about 40%, but it was even lower in patients taking atorvastatin. So what if you break it down by the severity of the hearing loss? What we find is it's not the grade 1 hearing loss that decreases, but the grade 2 and 3. So the really severe hearing loss is really dropping out in patients taking atorvastatin. So that has led us to design a randomized placebo-controlled trial, which I'll tell you about a little bit later in the talk. So the next thing I learned about statins was a trial that was done by a group of investigators in France. And this was brought to my attention by my colleague, Bill Stokes, who's a radiation oncologist at Emory. He didn't do the work, but he's the one who basically told me about it, which I thought was pretty provocative. These are patients who had really bad radiation fibrosis of their neck after treatment of head and neck cancer. And they were started on pravastatin a year later. So delayed treatment of their radiation fibrosis. And you can see this waterfall plot, how much of that decreased by more than 30%. And they did this with punch biopsies and also with high frequency ultrasound. I think you can appreciate the difference in this graph with fibrosis density going from over 20% to less than 5. And the fact that you could do this in delayed fashion, to me, was just incredible. And we started doing this sort of off-label in a lot of our patients with really bad fibrosis. Now I'm curious to see if it'll affect not only fibrosis of the skin of the neck, but the muscles for swallowing, right? That's another major area that takes a hit with radiation. And then there's also some data to suggest that statins prevent stroke in our patients who have had radiation. So if you look at our general population, the incidence of stroke over about 13 years is about 3.5%. But in NPC survivors who have had chemo and radiation, it's almost 4 times that much in that same period of time. And what's really striking is that our patients who have HPV positive disease have a really high incidence of delayed stroke for reasons we don't really understand. So this is data brought to my attention by Jennifer Dorth, who's a radiation oncologist at Case Western. And Jen, based on this data, has been trying for 10 years or more to get a big cooperative group trial started at ECOG Akron to treat patients with statins to avoid radiation-induced stroke. So if we look at whether that's supposed to work, if you look at carotid intima media thickness change as a surrogate for stroke risk, it does correlate directly with the amount of LDL cholesterol in the blood. And indeed, we do see a decreased risk of ischemic stroke and TIA in statin users versus non-statin users. So, so that trial, finally, after 10 years of Jen pushing, is making its way through steering committee at NCI, and hopefully will be coming to multiple centers near you. And the main outcome of that is going to be a stroke, and she wants to use rosuvastatin. And then we hope that hearing loss can be identified as a secondary outcome. So, some ethical questions came up. This is the reason it took Jen 10 years to push this idea, because there's some, she was pitching this to the cardiotoxicity committee at ECOG Akron, which is full of cardiologists. And they said, is it really ethical to randomize patients to placebo or no statin when 50% of our patients really should be on these drugs? And, the other people wonder in our hearing loss studies and otherwise, does statin therapy negatively impact survival? It's all fine and well if it prevents toxicity, but what if it actually negates some of the effects of radiation and chemo? We don't want that. So we'll come back to these in a second. So, as I'm, writing a grant to get funding for a big multi-site randomized placebo-controlled trial, I'm, trying to make an argument that statins are not going to decrease survival in our patients. And it turns out there are a couple of big database studies that make that point. So looking at SEER Medicare data, my colleague Bill Stokes is involved in this study led by Sana Karam when she was at University of Colorado. When they looked at SEER Medicare data, they found that patients who had lipidemia and were on statins had a better survival than patients who were not on statins when upon diagnosis of their head and neck cancer, despite the fact you may argue that the statin-treated patients may have more comorbidities. And the same thing was shown in a big database registry at the Ontario Cancer Registry in Canada. So, I'm scratching my head thinking, how does this happen? I'm also, not just studying cisplatin toxicity, but I also really care about curing cancer. So it turns out emerging data suggests that manipulating cholesterol can enhance anti-tumor immune responses. And there was a paper by a multi-center group in Italy that came out 4 years ago where they looked at what patients were taking along with their anti-PD-1 immunotherapy. And they looked at PPIs and beta blockers and all kinds of different things. And they did find that statin users were more likely to respond to anti-PD-1 with an odds ratio of 1.6. Didn't impact survival. And this wasn't head and neck cancer. This was melanoma, lung cancer, and renal cell cancer. And they didn't have any data on specific statins that were used. And I actually just got in touch with Alessio Cortellini a month ago, and I said, please tell me you have data on individual statins. And he said, I'm sorry, I don't. So, that's a bummer. But we hypothesize that this may be the mechanism by which statins are improving survival in our head and neck cancer patients. So luckily for me, I'm a little bit of a amateur tumor immunologist. So before embarking on animal studies, I decided to look back at our institutional experience. So this is looking at Emory head and neck cancer patients treated with pembrolizumab or nivolumab, and we specifically limited it to patients who got at least 3 cycles. Because, if you're getting 1 cycle and you're not even giving the drug time to work, it's really not a fair comparison. A lot of our patients really do succumb to their disease early on with immunotherapy treatment. So we found 158 patients for whom we had good data, and they had 3 doses. And we looked at response. In other words, did their tumor shrink on imaging, or did it stay stable, or did it get worse? And of patients who had an objective response as their best first outcome, only about 15% of patients that weren't on statins. But if you looked at patients on any statin, now we're looking about 30%. And, let's see about individual statins. So atorvastatin is actually not our best drug, which would be too convenient because it protects the hearing, but it actually wasn't even significant, but it appears to be a similar rate of response. However, when you look at rosuvastatin and lovastatin, now you're talking, 40 to 50% response rate with a highly significant odds ratio. So we weren't powered to look at survival by individual statins, but if you just compare all statin users versus non-statin users, We almost saw progression-free survival improve. This P of 0.057. We've all been there. It's kind of the story of my life, but hopefully, people will be convinced by this. And keeping in mind that most of these patients in the red graph were on atorvastatin, which is our least promising drug in the graph on the left. So I would hope that if we used rosuvastatin or lovastatin, we might see a bigger difference. And so that's what we're going to do in the future. Meanwhile, we wanted to kind of look at this in mice, and we were seeing some really compelling data in a growing body of literature suggesting that these drugs are helpful. So whether you use statins or PCSK9 inhibitors, which are fancier drugs used for severe refractory or familial hyperlipidemia, they're expensive and they're still on patent. But in any case, what people have found is that these drugs can reverse T cell expression of PD-1 and other co-inhibitory checkpoints. They increase T cell production of IL-2, which is a cytokine that tells T cells to proliferate. It enhances T cell production of cytokines and cytolytic granules. These are happy T cells when they do this. And then it also improves MHC class 1 recycling, which helps the T cell recognize the tumor cell. And finally, what we really care about is it seems to enhance responses to anti-PD-1 therapy in animal studies. So what about head and neck? These models are colorectal and other cancers in animal models, and no one had looked at this to our knowledge in an animal model of head and neck cancer. So we wanted to do that, but where do we start? There are 7 of these drugs commercially available, and which one is best and what dose are we supposed to use? We had no clue. And the literature uses all kinds of different drugs and often gives them by IP injection and IV injection and sometimes oral gavage, but we wanted to use it similar to how our patients are taking it at physiologic relevant doses, and we wanted to figure out which of the 7 drugs is best. So we use this high throughput impedance assay to test them all. And so the way this works is we have a 96 well plate. We put tumor cells in each of those wells, and each well has these 2 electrode rays on the bottom of it. So there's a current that goes from the negative terminal to the positive terminal. And as cancer cells grow on the bottom, they impede the current, and the computer recognizes that as cell growth. If then you add a drug or an immune cell on top, and the immune cells don't typically sink, they float, and they don't directly affect the current. But if they kill the cells and the cells lift off the plate, then that electrical current goes back up, and that's detected as a cell death or a drop in proliferation. So we did this with all 7 drugs. What we did was we took basically a mouse tumor cell line, put it into a mouse and grew a tumor. Then we take the tumor for the sole reason of borrowing the tumor infiltrating lymphocytes, or TIL. So we'd culture those with IL-2 and expand those for up to a couple weeks. And when the TIL were ready, we would then load this plate with the same tumor cell line, let it stick overnight, add the T cells, add the statin drugs, leave for the weekend, come back on Monday, and we had 96 gorgeous data points. And so this is what we saw, is that we did this with all 7 drugs, and we narrowed it down to really simvastatin and lovastatin being our best at what we find are sort of peak serum concentrations in humans. And so here I'm showing you the control cells, which in the black line, they eventually run out of space after about 4 days and they start to drop. The gray triangles are when we added TIL at a 5-to-1 ratio to tumor cells. So there's some killing there or decreased proliferation, hard to say, but it's modest. Then we saw a dose-dependent decrease in cell proliferation when we added simvastatin, same thing with lovastatin. And our best results were when we added the TIL and the statin at the same time. And so you see these cells weren't able to grow much at all when they had simvastatin and the TIL. And so this way, we narrowed it down to a couple drugs. But if you look at these, we're not seeing a home run when we add these 2 things together. It really looks additive rather than synergistic. And we wondered, is the statin just acting on the tumor cells and preventing them from dividing, or is it also having some direct impact on the T cells? And so we did another experiment where we just took the T cells and pre-treated them for 24 hours with statin, and then added them into culture without any additional statin, and compared that to TIL or statin alone. And we got a near home run when we did that. So this would suggest that there is some direct effect on the T cells themselves. So what is it doing? So first we wanted to see if it actually works in an actual mouse with cancer. So here we took this mouse oral cancer 1 model and we injected it under the skin of an immunocompetent animal and wait for it to grow. And then we treated the mice with either anti-PD-1 immunotherapy twice a week or statin drug by mouth every single day for 3 weeks, just like a human would be taking it. And what we find is with both simvastatin and lovastatin, here I'm showing you the animal's tumor growing. Individual animals are shown. So gray is a control, anti-PD-1 here is red, and 0 of the mice in that group rejected their tumors or were cured. Same thing with lovastatin when we used it by itself, but when we treated them together, we saw some delays, and actually 30% of the mice rejected their tumors and were cured. And we let them, hang out and watch Netflix for a month, and then we re-challenged them by putting the tumor cells in their opposite flank, and they failed to grow those tumors, suggesting they had immunologic memory to this tumor cell. But when we also did the same thing but depleted the CD8 T cells, then we lose our effect. So that really suggests that this is a CD8 T cell driven mechanism. And of course, with the combination, we saw increased survival. And I have to say that even though this paper was published last year, this model of putting tumor cells under the skin and the flank is already obsolete. So all of our labs, almost nationwide at this point, have moved towards an orthotopic model where we put these cancer cells back where they came from. These cells were made by Ravi Palluri's lab, where they exposed mice to carcinogens until they grew tongue tumors, and then they made cell lines. So our lab likes to put them in the buccal mucosa right at the oral commissure. And you can see you grow this really nice buccal tumor that ulcerates into the mouth. And then if you do lymph node mapping, we did sentinel node mapping, and we found that it does drain to a level 1B lymph node right next to the submandibular gland of the mouse. So it's kind of like real life. And when we repeated these experiments, this is data from Monday, we actually are seeing that it works better in an orthotopic model, which is more representative of the disease that we're treating. And again, this is an ongoing experiment, but it looks like all of these tumors that are treated with combination are going to reject. And it doesn't seem that impressive until you realize that, to get these kind of results in a mouse model or in humans, typically we have to do radiation or surgery or some pretty massive local therapy. So here we're using 2 FDA-approved systemic drugs, and we're getting a home run. So back to this experiment, we also did some flow cytometry on the tumors and the lymph nodes during week 2 of treatment in a subset of animals that were euthanized. And what we find is that the T cells in the draining lymph node are more activated. They had increased interferon production and increased CD107 expression, which those are kind of generic, non-specific markers of T cell activation. So we don't really know what is the true underlying mechanism for this. So we got some clues by talking to a medical student who was working in my lab for a bit. He had done his PhD on T cell receptor signaling at Georgia Tech. And when he heard about this project, the light bulb went on for him, and he said, wait a minute, there are some papers suggesting that the amount of cholesterol in the T cell membrane changes things. It changes TCR signaling. So it actually makes the T cell receptor switch from an on state to an off state, or backwards. Actually, if you lower the cholesterol, the T cell receptor is more on and more receptive to recognizing its cognate antigen. So that was really interesting. So he introduced me to his PhD advisor, Chen Zhu, who's now one of my close collaborators. And we started looking at the literature. What we realized is that T cells actually do accumulate cholesterol when they traffic into the tumor microenvironment. So that would put them in more of an off state, according to the paper I just showed you. And we also found data suggesting that the LDL receptor, which, as I told you, increases on the cell surface with statin therapy, it also interacts with the TCR complex to enhance downstream signaling. And at the time, the Zhu lab had actually just done some experiments to show that T cells in the tumor microenvironment, and by that I mean in the tumor and the draining lymph node nearby, were dysfunctional compared with the same T cell anywhere else in the mouse's body. And what we wondered is, could cholesterol be causing that, and can statins rescue the T cell function? And the short answer is we think it does. So this is a cool experiment, and I'll have to explain it from my, surgeon scientist perspective, not being an engineer, because these guys are engineers. So what they do is they take 2 micropipettes, and they take a T cell that is specific for a known antigen. This particular T cell responds to ovalbumin, which is a chicken protein. And then they take a red blood cell from a volunteer, and then they coat it with a class 1 molecule loaded with that same antigen, so ovalbumin chicken protein. And then what they do is a poor graduate student sits under the microscope and counts how many times these two things connect. And the number of times they connect and the force of their connection leads to a shearing force in the red blood cell, which is detected by the other micropipette. So they sit there for hours and measure this. And what they find is that, you know, the experiment they had done before I met them was in these T cells in the spleen and a random lymph node have pretty good affinity for their, you know, target. But when they take the same T cells from the tumor draining lymph node, it is reduced. So if we take that same experiment, but we treat the mouse with statin by mouth for 4 days before we take the T cells out, that difference is gone. And we've done this a few times. This is all done in the orthotopic model I just showed you. And now we're looking at some other measures of T cell receptor signaling, which is pretty cool. So what's next? What are we doing now? Back to the hearing loss project, we are now doing a randomized placebo-controlled trial of atorvastatin for prevention of cisplatin-induced hearing loss in our head and neck cancer patients treated with chemoradiation that's cisplatin-based. And so we got a UO Run grant to do this at 4 sites. Emory is the lead extramural site, but we're also doing it at Rochester and University of Maryland. Our central coordinating site is NIDCD, and we have an excellent statistician from Portland, VA, who has a lot of experience in hearing loss studies. So the patient comes in, they get an audiogram, we check their lipid levels, we check to make sure their LFTs are okay. And if they are, we randomize them and they get placebo or atorvastatin, we don't know. They continue that until they come back for their 3-month PET scan, and at the same time, they stop their study drug, and they also get a audiogram. And we're also doing some patient-reported outcomes on neuropathy and radiation fibrosis and other things. And then we'll do another delayed hearing test in 2 years. So far, this is up and running. We got it up at all 4 sites, and and I think we're now 7 patients enrolled. And again, just to mention, again, this is team science. These are wonderful people. These are just a selection of the people that have helped get this trial off the ground. So back to those ethical questions I posed earlier, is it ethical to randomize patients to placebo or no statin when half of our patients should be on them? How do we get around that? So what we did was we realized a lot of our patients really should be on them, but they're not. And are we really going to see every patient and randomize them to, you know, and put them on a statin? Probably not before they start their chemoradiation. But in this particular case, we're going to stress the importance of cardiology follow-up. So Anant Mandawat is a cardiologist by training, but he's a cardio-oncologist. In other words, he specializes in cardiac complications in cancer patients. And he's put it upon himself to evaluate every single patient on this trial to determine whether they should be seen by a cardiologist himself or someone else at another institution to determine whether they need to be started or stay on a statin after the study is over. Because it's kind of dangerous to just pull somebody off of a statin because that can actually destabilize plaques and lead to cardiac events. And lastly, you know, again, the other ethical question about whether statin therapy negatively impacts survival, we have plenty of data now to suggest the opposite may actually be happening. So that's actually going to be a secondary outcome in our trial, and we hope to show non-inferiority in our statin group versus our placebo group. So I continue these collaborations with the Zhu Lab at Georgia Tech, and we're looking at not only the 2D affinity that I just showed you, but the force of those T cell receptor bonds with their cognate peptide MHC. We're also looking at calcium flux, and we're looking by imaging cytometry whether they actually change the amount of calcium in the T cell receptor membrane. And what we really want to do is validate those findings in a human study. So what does that human study look like? This is a trial that is literally about to open hopefully next month. We are planning to treat patients with recurrent or metastatic head and neck cancer with pembrolizumab plus lovastatin, since that was our most promising drug. And we're going to go at the highest dose because some studies outside of head and neck cancer suggest that the amount of lipid lowering is important, and that's how this hopefully comes about. So then we'll be checking LFTs throughout the patient's treatment because that's standard with pembrolizumab, but we'll be checking a lipid panel and collecting blood for research after the 3rd cycle. And if the patient is doing well and not having toxicity, we'll continue for up to a year after that. So our primary outcome is response. The typical response for this patient population is about 18%, and we hope to increase that to 40% with lovastatin. And in our retrospective data set, you may remember it was as high as 50%. And then we'll have some secondary outcomes, and we'll also bring blood and tumor tissue back to the lab to study the changes. This study and the preclinical work I showed you in mice is made possible by a really awesome organization that's linked to Emory called the Morningside Center for Innovative and Affordable Medicine, which was a nonprofit started by our former dean who was really interested in drug repurposing. So when you land into an arena where you want to do drug repurposing and your dean also supports that mission, it opens up some opportunities for help and for funding. So we're really excited about doing this hopefully very soon. So what's our end goal here? Are we trying to get FDA approval for statin drugs to be used for head and neck cancer? Not really. There's no financial incentive, and it costs millions of dollars to get an FDA registration for any drug. But what our goal is really, in talking to this wonderful guy, Taufik Awanakoko, he was a medical oncologist at Emory when I got here, and now he's the cancer center director at University of Maryland Greenbaum Cancer Center. And I had, he actually, when he saw our paper with retrospective data, opened up a similar trial in some community health clinics in Pittsburgh, where he was at the time. And I had a lovely chat with Taufik where he said, our goal is really to incorporate these drugs into the NCCN guidelines for cisplatin-treated patients, and not just for head and neck, but testicular cancer and ovarian cancer and any cancer where this is used on a somewhat regular basis. So that's really where we hope to go, and we hope our trial will provide level 1 evidence for the NCCN guidelines. So, it turns out I think our patients really should be on statin water, and I hope we'll continue to get some evidence in favor of that. So it looks like I may have enough time to do 2 minutes of unsolicited advice, which I like to do when I visit another department. I'm now 11 years out of residency and 9 years out of fellowship. So, you always, as a trainee, you get that question, where do you see yourself in 10 years? And I will say that I am exactly where I wanted to be. It's not exactly what I thought I would be doing. I actually didn't realize I'd be doing this much in clinical trials. So where I am right now is truly my dream job, and it's beyond my wildest dreams. And so here are a few pearls for the younger folks in the audience that I wish I knew 10 years ago. The first one is, I think it's really important to find your people. It took me several years to find the right job with the right people where I can really thrive. This is our cancer center director bragging about our collaborative environment here at Emory. And I noticed that the minute I walked in the door for my interview, and I realized I wanted and needed to be here. So that's huge. The next thing I'll say is life is really messy. So I have 2 boys, a mom of 2. That definitely complicates things. This is my 7-year-old on the left. Now, he was younger at the time. He's now 7, and he's messy in the very traditional way. But my 10-year-old in the middle, he's an adorable kid, but he's also, he suffers from level 3 autism, and he's non-speaking. So he communicates with an iPad, and we're teaching him how to point at letters on a letterboard, but he can read and do math, and he's just an incredible kid. But when he gets a sensory overload and melts down, the world stops. And what we end up with, this is a picture I took in our house this morning of a hole in the drywall that he created when he was out of control during a meltdown that my husband is now trying to fix. So, we spend a lot of our time driving around to different therapies and me searching PubMed at midnight for the latest silver bullet to help make his life easier. And if I didn't have kids, I wouldn't have to deal with this, and I'd have a little bit of edge in my career, but again, that's not living for me. I feel like the more we live, the messier life gets. And I think I've learned over the years to just embrace that and just go wherever it takes me, because in many ways, this has made me a little bit more compassionate person and a better oncologist. The other thing I'll say is work-life balance it does exist, but it's your responsibility. So I like to think of these gauges between work and life, and where this dial goes is really up to you. In residency, you don't have a lot of control over it. You just work, work, work. But when you are looking for a job and when you're on faculty, it's really up to you to find a job that's going to allow you to put this needle where you think it should be for you. For me, I'm usually in this kind of top one, right in the yellow range, and that kind of makes me tick, and I like that. And sometimes I get into the red zone when I've got, like this month, 3 R1s due, but I don't let it stay that way for long. And I always try to take breaks, and my research mentor from residency, Ed Rubel, used to say, you have to pencil in your leisure time because when you love your job, you're at risk of letting it consume you. So I think that's really important to do. I also would say nix the naysayers. This is a slide I've showed at many institutions, and I'm happy to show it here where you guys actually know this person very well. So when I was a resident, I asked Dr. Grandis for her advice for me. In addition to saying, have your babies when you can and don't worry about everybody else, the other piece of advice she gave me was don't listen to people who say you can't do it, because the people who say that are not doing it. And I had never forgot that. The last thing I'll say, and I'm going to use a little country music lyrics here: do what you love and call it work. I grew up out west where I never thought I would ever listen to country music until I moved to the South. But this is something that Bob Ferris said to me during my fellowship when I was crying in his office, telling him, I don't think I'll never make it as a surgeon scientist. Who am I kidding? And he says, I tell myself every day I'll never make it, but I keep doing it because I love it. So if what you love is going out into private practice or being a surgeon scientist or whatever it is, life is way too short to do what other people think you should be doing. I've had people tell me that, hey, you're doing a lot of clinical trials now. Why don't you just give up your wet lab? And the answer is, I love my wet lab. And so I've got my boxing gloves on as long as possible. And if I stop loving it, then maybe I'll pivot to a new direction. But for now, this is what I'm doing. So as I said earlier, this is team science. I have some wonderful people in my lab who've been working on some of these experiments, and a laundry list of collaborators, just to name a few here, that worked on the things I showed you. And our funding is mostly from NIDCD and also from the Morningside Center that I told you about. So I know that was a whirlwind. I appreciate your guys' attention early on a Wednesday morning, and I'd be happy to take any questions.
Thank you so much, Dr. Schmitt. That was a phenomenal talk. And I'm already getting comments from co-residents just talking about how special it was for you to give that little snippet at the end. We're saying we should now do this as a tradition for all of our grand round speakers, because there's so much knowledge that I think is hidden behind the scenes that we would benefit from. So thank you for sharing with that. I will kick us off with a quick question, and then I'll open it up for others. I feel like we recently had our head and neck course, and one of the complicated challenges that I see in head and neck therapy is there's just so many combinations of possible therapies, whether combinations of immunotherapy, combinations of how we stage therapies, radiation, surgery, immunotherapy. And if statins are these potentiators for T cells based on how much lipids are in their membranes, could you talk a little bit more about when they should be incorporated into the clinical algorithm? Like, for example, should we just start them even before they start their immunotherapy? And then, is there a role in just maxing out the dose beyond what we typically use for hyperlipidemia? Is there a role in using it for patients who aren't undergoing immunotherapy, where just having that potentiated T cell would be helpful? So just surgery or radiation.
Yeah, I think it's gonna play a role. And as I said, there's so many combinations. Most of them are fancy drugs by drug companies, so they don't love what I'm working on at all. But I think, as you guys probably know, and if you guys ever have a resident didactic time and you want to do an immunotherapy 101, I've been doing that for our residents for many years and other departments. But the paradigm is shifting. Instead of giving immunotherapy on the back end, we love to give it while the antigens are still there. The antigens are in the tumor, and while the lymph nodes are still there, because that's where the T cells live, right? So if you have a tumor in a lymph node and you want to use immunotherapy as a vaccine and then take the tumor out, that's where things are moving. And I think when the Keynote 689 trial matures, and if we see that giving people 2 doses of pembrolizumab before surgery actually improves survival, I think our world is about to dramatically change while some of you guys are still in training, which is very exciting. So then I think the trials that are going to be coming out are immunotherapy plus drug X in the neoadjuvant or pre-surgical window. And so right now we're studying them on the back end, because that's where you start. You start by, giving people, add the statin to their pembrolizumab, which is standard of care. It's not randomized. Patients love to know what they're getting. They know it's an FDA-approved safe drug, so they'll do it that way. But I think I see us putting it up closer up front. And I think a lot of us, you guys have some similar studies open at UCSF. So I think that's where the future is going.
Okay.
Nikki, just as a practical thing, great talk, first of all. Thank you so much for joining us. Um, are you putting people on statins even if they're not on trial or thinking about it? Or
Sometimes, I mean, now, a lot of the problem is a lot of our patients are on statins already, which is great. I've been trying to accrue for this hearing loss trial, and everybody's on a statin already. So we don't mess with that. If they're on it, we don't mess with what their cardiologist did. But, I saw an orthopedic surgeon with oropharynx cancer before the trial opened for hearing loss, and I said, hey, listen, you're going to get cisplatin. And I had this high level discussion with him about this, and I put him on atorvastatin off label because the trial wasn't open yet. So, and then my friend Bill Stokes is putting a lot of patients on it for radiation fibrosis. If they look very fibrotic, he just puts them on it. So, it's CME. I'm not supposed to talk about off-label use of drugs, but I'm just telling you that, yeah, it has changed our practice patterns. And I think that's where we're hoping this will go, is that it'll become standard of care.
thank you from my end for joining us this morning. It was really fun to hear. And great to see that you're doing so well out there.
Thanks for having me.
Okay, well, if we have no other questions, I just want to thank Dr. Schmitt. Truly was a wonderful Grand Rounds. And we were so grateful for how you artfully crafted this talk that wove so many different parts of career and innovation in head and neck cancer. So thank you so much for your talk this morning. We really appreciated it. Thank you very much.
Thanks to all of you. Have a great day.
Thank you so much. Have a great day.